A warm welcome to all viewers and listeners interested in sleep medicine and sleep research wherever you are in the world. We are delighted to welcome you to our very first broadcast. It's called Sleep Lab with Netzer and Popovic, and we want to introduce you to some details that might interest you. What happens in a sleep laboratory? What are the latest news on certain sleep medicine disorders or research topics? And I'm pleased that I'm not alone here in the studio, but joined by my longtime friend and colleague Rainer Popovic, who has also been in sleep medicine for 40 years. Go ahead, Rainer.
Yes, that's right. I would also like to warmly welcome everyone. A heartfelt service from me as well. My name is Rainer Popovic and I'm from Vienna. And as Nikki has already correctly pointed out, our time in sleep medicine has spanned many decades and is already a very long one. And we are still very enthusiastic about sleep medicine and want to present you with interesting topics in the upcoming episodes as well.
You always flirt a bit with the idea of retiring, but honestly, truly retiring, we never really do that as a society, do we? How long were you actually president of the Austrian Society for Sleep Medicine?
Well, strictly speaking, I was president twice. The first time I tried, so to speak, to do justice to my job. That was from 2004 to 2008. The second time was from 2018 to 2022. By then, I already had certain ideas about where sleep medicine should lead us, and I tried to implement those. That was the difference between the two periods. But perhaps more importantly, over the course of my life, I have established and led 3 sleep laboratories. That also speaks to my enthusiasm for sleep medicine. And as you rightly said, I'm actually already retired, but I'm still, so to speak, active in sleep medicine and just can't quite let it go.
We actually have something in common. We both spent a longer period in the USA. You were with David White, first in Denver, and then he moved to Harvard. And I was with Kingman Stroll in Cleveland. What were the most important things you brought back with you from the USA?
Well, on the one hand, I learned and saw that people work very differently in America. That means much more concretely, much more precisely. For example, my boss always took the time before his lectures to rehearse them for himself 2, 3, even 4 times. That's something that's almost never done in Europe. And on the other hand, even back then, I was already working on a very important topic, namely the gender-specific differences in medicine, which particularly interested me in the field of sleep apnea. But you were in the States long enough yourself. What was your experience like?
Yes, both of us have. I also focused on the differences in sleep medicine between men and women. Diverse, depending on how you want to look at it. But in any case, my impression was also, I would say, a really quite intensive work in all areas. A thorough analysis is definitely important. And for me, of course, the most important thing for many years was a project involving a questionnaire that's widely used in sleep medicine, but we'll get to that in a later episode. I think we should stop patting ourselves on the back now. Dear viewers, we are now turning to a topic that is somewhat new territory or a bit challenging for both of us, but also very current, namely chronic fatigue syndrome, that is chronic tiredness. It should be mentioned that Rainer was actually against us doing this because, as I said, it's a bit more difficult for both of us as well. We're not from this field, but I was a bit stubborn, insisted on it, and said, let's start with a current topic. Rainer, for a long time, chronic fatigue was kind of the black sheep of sleep medicine. So when someone came to a sleep lab or even to a doctor and said, yes, I have this fatigue, they would examine and examine and examine and find nothing. And doctors sometimes have a tendency when they don't know something. Back then you just had something, that's what they would say. I still remember they would call it something like a vegetative syndrome or something. That was an expression they used when they didn't know what it was. And then in sleep medicine, it was kind of like chronic fatigue syndrome, but that's changed, hasn't it?
That has changed a lot. I remember when I was still studying or was a young doctor, I first encountered chronic fatigue in connection with the field of rheumatology. That means back then everything related to chronic illnesses that couldn't be clearly defined was pushed into that corner. I think chronic fatigue only really became well known in the context of COVID and especially with long COVID. And so it's actually not just a topic for sleep medicine, but I find it interesting that you chose this for the first episode.
Yeah, like I said, I wanted to pick a current topic so that we get a lot of first-time viewers for this episode. And you have to say, just as you already pointed out, COVID changed everything, especially, of course, long COVID. We know there are still a lot of people affected by long COVID. And it was actually through long COVID that we discovered that this chronic fatigue is probably more likely triggered by viruses that probably destroy certain structures in the brain and, so to speak, cause inflammation in the brain.
Absolutely right. That's the new approach to explaining this chronic fatigue syndrome. But let's ask a woman about it and see what she has to tell us.
Yes, but before we ask the woman, let's briefly go into detail, because by now there is actually a kind of investigative pathway that can be followed. As previously mentioned, it is widely assumed that it is not merely an inflammation within the brain accompanied by the significant destruction of certain specific neurons, but also that it is not exclusively the brain that is adversely affected, but rather the muscles as well, playing a crucial role in the overall condition. And that's why it's now also called chronic myoencephalitis, myo for myalgia, meaning the muscles are affected, and encephalitis for inflammation of the brain. And before we talk to our patient, let's briefly look at the corresponding scheme for how best to diagnose chronic fatigue from a clinical perspective, because that's currently the only way possible. You can't just simply take a sample from the brain.
That's right. It's a complex topic and you have to start somewhere. And the more specific you get, the more you realize that we still don't know as much about the subject as we would like to.
When trying to accurately diagnose chronic fatigue syndrome, which is now also frequently referred to as myalgic encephalomyelitis, doctors meticulously follow a systematic approach in which certain crucial key symptoms are carefully confirmed or definitively ruled out. After other physical causes have been ruled out, the following criteria are especially important. First, fatigue and exhaustion must persist for several months. Second, the exhaustion worsens after physical exertion, even if there is a slight delay before it sets in. Third, there is a reduction in cognitive performance, which can manifest as difficulty concentrating or memory problems. If these sufficient indications are present, the diagnosis is considered largely confirmed, even without lab tests or instrumental examinations.
Yes, Rainer already mentioned it, that we're almost lay people, even if we've been working in sleep medicine for 40 years, already involved in this field. And that's why we said, let's ask the leading expert in Germany on the topic of chronic fatigue and long COVID, Professor Scheibenbogen from Charité in Berlin. And now I have the honor of conducting a short interview with her. Dear Professor Scheibenbogen, thank you very much. First of all, warm greetings to Berlin and thank you very much for agreeing to this interview. You are deeply involved in the topics of long COVID and chronic fatigue syndrome with your outpatient clinic at Charité. What can you tell us? What is currently the best scientific explanation for how chronic fatigue syndrome can develop?
Yes, during the pandemic, we have come to understand quite a bit more about this illness. And today we know that, at least for some of those affected, it is a disease of the immune system that is triggered by a severe infection. And we see this as well in some of those affected after COVID. And so there are indications on the one hand of ongoing mild inflammation, but also of autoimmune processes. And as a result, the whole body ultimately becomes disrupted, especially the regulation of the autonomic nervous system and energy production. However, I would like to add that the mechanisms in ME/CFS are not the same for everyone. But that's no different from other diseases, such as multiple sclerosis, for example.
Which specific parts of the immune system are affected by the attack of the viruses?
So with COVID, for example, we see that inflammation often persists in the body for a long time. For instance, the blood vessels are often infected and then heal poorly. We also see inflammation in the brain. There was just a large study from Yale that demonstrated this very clearly in the cerebrospinal fluid. And then autoantibodies play a very important role. These are antibodies that we initially produce against the viral infection, but which can then also lead to malfunctions and target our own body, attacking important structures. There are two animal models that show that when these so-called antibodies or immunoglobulins from patients are transferred to mice, the mice then develop very similar symptoms.
Now, of course, we can't practically take actual samples from the delicate spinal cord or perform, for example, invasive procedures, other extensive laboratory tests. And the cardinal symptom is considered to be, above all, this exhaustion after even slight muscular exertion, especially with a certain delay. How do you see that? Is that the main cardinal symptom, or how do you assess it? How do you conduct diagnostics in your outpatient clinic at Charité?
The diagnostics are based, on the one hand, on the simultaneous occurrence of various symptoms. There are diagnostic criteria, just as with other diseases, and the central symptom is this: that those affected can hardly exert themselves anymore. So this exercise intolerance is very pronounced in this disease. This then leads to what is called post-exertional malaise, or PEM, meaning a worsening which can affect all symptoms, often triggered by completely everyday activities. And the terrible thing is, this often lasts for days or even weeks, and is accompanied by a heavy burden of illness, often with severe pain and serious sleep disturbances. And regarding the muscle weakness itself, that's also an important diagnostic criterion because it can actually be measured. For example, using grip strength measurements, you can see that many patients have hardly any strength left. They might have been able to pull 30 kilos before, and now they can't even manage 10.
So a hand dynamometer, since I partly come from geriatrics where it's also an important tool, you would strongly recommend that as well. Perhaps for general practitioners or for other levels below your university outpatient clinic, to provide some initial support in making a diagnosis.
Yes, we recommend that as well. It's also quite inexpensive. You can get such a device for 25 euros. And in Berlin, we also work together with a network of general practitioners. And it's a very simple test. And we've noticed with COVID, we've now learned that this occurs very early on. As soon as 3 months after infection, we see that grip strength declines, and we also see that it's prognostic. The weaker the grip strength, unfortunately, the higher the risk that the illness will become severe and chronic.
In the diagnostic scheme, it also says that cognitive problems can occur, so to speak. Are those also diagnosed, and which ones do you see in your patients?
That's also another very typical symptom of ME/CFS and often of post-COVID as well. There is some overlap there. Those affected describe this as brain fog, often the inability to concentrate for extended periods. And if you want to test it, there are various tests that can objectively measure this. In particular, attention is especially impaired.
Now, in addition to all of the extensive research findings that you have already thoughtfully mentioned in your comprehensive answers, there are also numerous important publications. There are also quite a few colleagues who, as was often the case in the past, primarily view chronic fatigue as a psychosomatic illness, with the physical consequences being more or less just a result of psychological issues. What is your opinion on this?
On the one hand, it is unfortunately often a problem of how the term is defined. Fatigue is, first of all, just a symptom that occurs in many illnesses, and this is often the case. It is not clearly distinguished from this disease, which is now internationally referred to as myalgic encephalomyelitis, also known as chronic fatigue syndrome, or abbreviated as ME/CFS. And the notion that this is a psychosomatic or psychiatric disorder is scientifically outdated. It is now absolutely clear that this is a serious physical illness with clearly measurable biological changes. Of course, a chronic illness, like any other serious disease, can also be psychologically burdensome, but the cause does not lie in the psyche. It lies in physical malfunctions in the immune system.
Yes, thank you very much. I see it similarly to you. Now, the situation is that a lot of people come to you. Your clinic is in high demand. People seeking help probably see you as the most well-known point of contact in Germany. A TV doctor once underwent dialysis on television to try to get rid of long COVID. But what are the methods or forms of support that you currently offer patients for therapy?
Yes, so at the moment, therapy is primarily focused on treating the symptoms. One very important aspect is what's called pacing, which means avoiding overexertion. Unfortunately, for those who are more severely ill, this often means they can't even manage everyday activities anymore, and as a result, they can hardly be active at all because otherwise they constantly risk severe relapses. But many patients also benefit from established medications for sleep disorders. That's very important. It's often where we start in treatment, addressing circulatory problems and pain. And for these symptom-oriented therapies, we have now written a comprehensive interactive practice guide from the German Society for ME/CFS. It's intended for physicians. It will probably be published on the DG-ME/CFS website as early as next week. This is also very important for doctors who don't have much experience with the disease yet. With this, we're also trying to make it more widely accessible. And there's also a so-called therapy compass from the BfArM. A decision is currently being made there about possible off-label therapies that could be covered by insurance. And with these tools, any general practitioner can ultimately provide symptom-oriented treatment to patients. And this guideline also provides very important support in diagnostics.
Now you've brought up an important topic, sleep medicine. Of course, I'm also interested in therapies for sleep disorders. Do the new orexin agonists now play a role in therapy as they are used in narcolepsy?
There isn't much data on that yet, and they are still only considered a second-line therapy. And we also proceed in a stepwise manner. So we always recommend melatonin first. That helps about half of those affected quite well as a basic therapy. And we need a treatment that can be given long-term and has little potential for dependency. And in that regard, we have very good international experience with low-dose antidepressants, especially doxepin in a very low dose, that is 2.5 milligrams, which is approved in Germany for sleep disorders associated with depression. In the USA, it is the standard sleep medication, so that's what we recommend. Or, if that is not sufficient, you can try trimipramine or mirtazapine. And then, as the next step, an orexin receptor agonist or, for example, athosil can sometimes also help in cases of very severe sleep disorders.
So it's probably a bit of trial and error. You can't really avoid that. Or rather, personalized therapy. You will probably have to try different things with patients to see what works best, right?
That's the case with almost all illnesses. But in some people, these sleep disturbances are so pronounced that they even lead to a complete shift in the day-night rhythm. And that's often really something you should start with in treatment, and where you can really help those affected if you can help them get back to restful, well, maybe not even truly restful, but at least sufficient sleep. Because sleep isn't truly restful with this illness. So typically, even if those affected have slept enough, they still experience severe symptoms the next morning.
Yes. Ms. Colligan, thank you very much for the interview. Despite all the work, I wish you a few restful summer days. And you've really provided us with a lot of good information. Once again, many thanks to Berlin.
You're very welcome. Perhaps as a final point, I would like to add a hopeful perspective. We urgently need effective curative therapies, and there are now very many promising concepts, including with medications we've had for a long time to treat cells that produce autoantibodies. Just last week, a study was published from Norway showing that a monoclonal antibody like a CD38 has high efficacy, at least in some patients. And these are exactly the kinds of therapies we also want to develop. We are also very hopeful that we will now receive funding from the new ministry led by Ms. Beer.
Well, then I wish you much success and thank you very much for being able to give a bit of hope to those affected. So there really is a certain light at the end of the tunnel and a bit of sunshine. And I wish you that as well for your work. Thank you again. Thank you for the interview.
Thank you. All the best.
Yes, that was a very interesting insight into a highly scientific topic. And perhaps we will also hear a comment from everyday practice.
And we will now conduct an interview with Dr. Claudia Sommer, who has been running a pulmonology practice in Garmisch-Partenkirchen for many, many years. Dr. Sommer, warm greetings to Garmisch-Partenkirchen. You have been running one of the most prominent pulmonology practices in Bavaria for many years, and we have known each other as colleagues for almost as long as you have been running the practice. Of course, we have also had many discussions about COVID. In 2021, I believe your practice was very busy with COVID patients. How many of these patients, what percentage do you think, came back to your practice later on with long COVID, that is, with persistent symptoms?
First of all, may I also say hello and thank you very much for inviting me here. Yes, let's go back to the year 2021. We worked continuously and saw COVID in every degree of severity. I think I need to break this down a bit. Back then, we had between 3 and 6 months of after effects, especially among hospitalized patients, and in fact up to 10%, but these symptoms usually resolved relatively quickly. After more than half a year, it was still about 5%, and today I would estimate it at a maximum of 1%. But of course, these are patients who over the years have been distributed among various specialties, so I may not see them anymore.
Have you actually been able to identify any connections to vaccinations? I'm asking because this is a topic that's been very widely discussed in public, and of course there are now more indications of possible problems with the vaccinations. Have you been able to observe more correlations in vaccinated or unvaccinated patients?
Those were isolated cases. For example, there was a patient, I'm also an environmental medicine specialist, who has MCS, that is multiple chemical sensitivity, so a hypersensitivity also to other vaccines. And she really developed classic corona symptoms that lasted for months. We basically had to treat her as if she had corona. Another patient whom I also know well personally, who is very active but takes blood thinners, actually developed a bilateral pulmonary embolism in direct, that is temporal connection with the vaccination. But as I said, these are case reports. Then we had young people whom I didn't know before, but who had received many vaccinations, who reported that the day after the vaccination, they suddenly weren't as athletic anymore, had trouble climbing stairs, even though just a few days earlier they had been out in the mountains, either mountain biking or jogging, and whom we had to treat as if they had asthma, often for 2 or 3 months until they were really fit again. Well, we haven't seen any permanent damage, but at least there was a temporal connection. But with these patients whom I didn't know before, especially female patients, I have to emphasize, as they were somewhat overrepresented. In those cases, we did see a need for treatment and at least a temporal connection. But the majority of patients tolerated it very well, and I personally vaccinated a lot of people with allergies myself. As an allergist, of course, I pre-screened patients with a history of anaphylaxis. I saw them particularly often in my practice, and we didn't have any adverse reactions.
Let's move on to the main topic of this episode of our show, chronic fatigue syndrome, which of course we also see as somewhat related to long COVID. Some time ago, there was an article in a well-known journal of neurology where chronic fatigue was rather viewed as psychosomatic. It was seen as a psychosomatic illness. We already had an interview here on the show with Professor Scheibenbogen from Charité in Berlin, who doesn't really agree with this theory. So as I said, in that article, chronic fatigue was actually seen more as psychosomatic, associated with psychological issues, and then resulting in physical consequences rather than as a direct result of a viral illness. How do you see this based on your own experience?
First of all, there are quite a few viral diseases that lead to fatigue. We know this, for example, from Epstein-Barr and similar viruses. So I do see a correlation there in principle. But what's interesting is when you already knew the patient beforehand. I believe there is a vulnerable segment of the population that simply tends to develop more problems afterwards. Specifically, some of these were patients who already had major psychosocial issues beforehand, for example, caring for relatives, people who were really at the end of their strength. They had family problems, work-related issues that we often discussed, sometimes openly, and also a bit asthmatic, allergic, in short, people who also suffered from depression. And I have to say, with them, we definitely see these symptoms intensify afterwards. I think this is simply a group that was already particularly burdened beforehand. The second group was completely different. They came in with suspected chronic fatigue, really just to get a checkup after having had COVID. And they simply had untreated sleep apnea syndrome. And in some cases, we were admitting 1 or 2 people a day who would never have come to our practice before, but they came because of suspected chronic fatigue. But in reality, the medical history had already been going on much, much longer. That means we actually found a condition that required treatment, which had nothing to do with it. And then there is the group that I still see to this day, who say that some days they can't get out of bed at all, and the next day they feel perfectly fine. So I do see these persistent cases. It's not a large number, but they are very difficult to treat, and also to address them psychologically.
Now, you've brought up a very important point, which is, of course, also very important for us as sleep specialists, that sleep medicine diagnostics should definitely not be neglected, even in patients who come with suspected chronic fatigue or complaints of chronic fatigue.
So that's definitely a key point. And we tried to screen 4 to 5 people every day. And in fact, we found 1 to 2 patients practically every day. Another thing you can do, which is quite interesting, is gas exchange measurement, which is already established in our practice. And with that, we were actually able to find patients who had problems with the transfer of oxygen from the lungs into the blood, and in some cases even developed what is known as lactic acidosis under minimal exertion, meaning an over-acidification, and then also muscle relaxation. And with these patients, I have to say, you can really measure directly what kind of progress they are making. And it took a long time, but most of them have now recovered. But there was actually a group that still hasn't fully recovered to this day. And I think that in this regard, it's naturally easier in these specialist practices because we do blood gas analyses, lactate measurements, and of course also gas exchange measurements so that you can, so to speak, distinguish patients from purely psychosomatic cases. And there's another measurement, but unfortunately it's not covered by insurance. That's FeNO, which means a measurement of metabolic products, eosinophils, in other words, an inflammation measurement. And the highest values I've ever measured were in these patients with this chronic fatigue. And reported episodes of weakness with values in the several hundreds, where 50 is already considered severe. And there I think you can really separate the organic from the psychosomatic to some extent.
Claudia, I truly think that's a really great recommendation, that patients should actively try to obtain such a no-FeNO measurement, which is not at all very complicated, since it's typically done quite simply via exhalation. They should definitely try to get this important measurement done for a much more precise and accurate diagnosis. But now let's move on to the topic of therapy. What does your treatment strategy look like for these patients with chronic fatigue?
So first, we try to get the lung function back to normal because in most cases, we already see some degree of impairment. It's also quite commonly recommended to treat it as you would asthma with medications that dilate the bronchi, which also have a bit of a stimulating effect, a bit of an energizing effect, since after all, they are derived from adrenaline. Then, of course, we also try in some cases to give infusions like vitamin C or vitamin B complex, which can be injected to provide some support. Then there are supplements that patients can take orally. These contain amino acids, trace elements, and vitamins. The next thing, of course, is that we also have to be aware that we are seeing immune system problems here. The patients are very, very sensitive, so we try to activate them a little. Here in Garmisch, we actually have a great opportunity for this, namely our respiratory trail. There, patients can go outside on their own and work on overcoming this avoidance behavior they have, these anxiety states, these panic attacks, essentially. Everyone has to become active for themselves. Individual physiotherapy is also very important, as well as physiotherapy equipment, and in some cases occupational therapy, and for some even speech therapy, so that they can simply regain more confidence. Light group exercise is also helpful, and there's even the option to do something like that in a pool, for example, just to round things off a bit, and of course rehabilitation as well. But to be honest, we have to say that we wait a very, very long time for appointments. And especially for specialized clinics that focus on COVID and long COVID, it gets even worse because they basically receive patients from all over Germany. So you really have to offer patients physiotherapy and similar treatments in the meantime. Then, yes, of course, we also try to treat the symptoms when they are highly acute, sometimes in the short term with oral steroids. For patients with high FeNO, we also use these so-called leukotriene antagonists. They don't just work for allergies, we've actually had quite good results with them. Then we provide patients with instructions for self-training. And one must not forget, these people are very, very susceptible to infections. That's also one reason why they recover so poorly. So we simply give them guidance regarding their vaccination record and say, okay, it's not just about the COVID vaccine, but also flu, pneumococcus, RSV, and pertussis. Because, for example, if we send them to rehab, they immediately catch the next infection, and that just sets them back again. And we've had quite a few patients who, as a result, didn't have any success with rehab. Yes, and of course, some psychosomatic support as well. So we arrange appointments, have many conversations, and try to generally help them rebuild, because I see that patients often really withdraw from everything. And I think that's a really important point with this chronic fatigue, that they learn to deal with it. If it's a good day, to do something, and if it's a bad day, to accept that as well.
Yes, Claudia, thank you very much for this truly interesting perspective from practice from the pulmonology clinic. Then I wish you a few more lovely days and send warm greetings to Summary Garmisch-Partenkirchen. And I think we'll surely see each other again in person in the next few days. Yes, so thank you again for the interview and have a wonderful summer day.
Thank you very much as well, Vitor. So until next time. Ciao, goodbye.
So that was our very first episode at the Sleep Lab with Netzer and Popovic, today featuring two interesting expert interviews. That won't always be the case, because thankfully there are also topics where Rainer and I know our stuff quite well and will guide you through the show ourselves. And as I said, yes, that was our episode on the topic of chronic fatigue. And Rainer, maybe we should say something to bid our viewers farewell. After all, we want them to watch the next episode too.
We started with a very difficult topic that was a bit unfamiliar to us, but as an introduction, it might not have been uninteresting either. Now I would like to move more concretely towards sleep medicine. And as we planned, we want to talk a bit about what sleep medicine encompasses, what it looks like in a sleep lab, and so on. And we look forward to welcoming you to the next episode. And for this episode, I hope it was interesting for you and that we can welcome you back for the next one.
Goodbye, everyone.
And sweet dreams.